Okay. So here's our bladder slide. All right. And you can just please just tell me what you are seeing. Okay. Yes?
So this is like muscles,
right? Muscularis propria. Good.
And there is some tissue here, like epithelium,
okay, so some urothelium, right?
Urothelium here.
How are you feeling about your urothelium?
Looks okay, but I don't see anything abnormal here.
Okay.
And the cells are parallel to each other, and to the surface there's some here there. Okay, there's some abnormality here. We see like large. Some of them are large. Can say this array of the cell of the.
Okay, so over in these areas, we say they're maintaining their polarity. Some of them are a little plump, but you're telling me it's okay. I'm okay with that. And then over here, they're starting to become a little disorganized. They're starting to lose their polarity, maybe a little bit of pleomorphism, right?
Yeah.
Okay, what else is going on here? What do you notice about this specimen?
A lot of inflammation, maybe hemorrhage area.
Right, there's a lot of hemorrhage. Is that normal in a bladder specimen?
Not really.
No, not really. You don't normally see something that's this bloody.
This is so much big. Maybe ulcerated area or hemorrhage.
Right, something's going on. Okay, don't do that. All right, so, and then what about these strips of urothelium? You're still feeling good about them, or you're thinking it's...
I'm thinking it's different now. Maybe I think a low grade here.
Yeah, you're thinking, oh,
Low
this
grade,
is...
or maybe
yeah.
high grade, but I think it's still low grade.
Right, so you're totally wrong. But good job.
Yeah.
So this is the trap that I was setting for you. So thanks for walking right into that.
Okay.
You're great. So here's the issue. Apparently we can't go to EM power. That's good to know. The scope doesn't go there. Okay. So when you look at a specimen, the first thing I want you to think about when you're dealing with bladder is you're going to ask yourself, first question, is it papillary? Okay. And before you immediately go to some detached piece of tissue and say, yes, it's papillary, you're going to want to look at the background, because when you have a lot of inflammation or a lot of hemorrhage, you can get polypoid cystitis, right? So the lamina propria expands and it can make it appear papillary when it's not, okay? So this is a huge pitfall. So something like this, that is not a papillary structure. There's no true fibrovascular core. That is just lamina propria that has swollen, okay? The other thing, oh, thank you. That's so much better.
That's okay.
There is now fire.
No. So I can't do that.
That's okay. We'll ignore it. What could possibly go wrong? So you notice there's a hemorrhagic background. So immediately you're going to be very cautious before you call anything papillary. The other pitfall people make is you take something like this, where you see lots of hemorrhage and things that are floating, and you want to call it a lesion. But remember, and this is the biggest pitfall for this, is actually in your ureteral biopsies, because you get strips of urothelium that are torn off, they fold around on themselves and make it look like some sort of papillary lesion. So don't be fooled by that. And remember, as much atypia as you are seeing here, that is all consistent with reactive change. Reactive change, you can lose polarity, you can get mild to moderate pleomorphism, and you can get mitoses like crazy, right? This is the joy that is bladder. So I will tell you that this is not a lesion at all. And this person has a lot of hemorrhage. And so when you think of hemorrhage in the bladder, there are really two entities I want you to think about. So can you think of one?
Catheter. Somebody shoves the catheter too far.
Yeah, that's, I mean, but think about it. Think of how many TURP or TURBT specimens you see. They don't look like this, right? A lot of those patients have catheters. Yeah. So this is more than that. I mean, this is bad, right? So, yeah, I mean, no one likes a catheter, but the bladder, I mean, there are very few things that will piss a bladder off to this degree.
This patient has type of medication. Medication effect.
Possible. So hemorrhagic cystitis, thinking about maybe they had like cyclophosphamide as a child or something like that, right? Okay. But that's not this. But that's possible. What else?
Can I get more history?
What is the history? You should see this and you should know the history. Okay, anyone? All right. So, woo, it went dark.
It's other side. Okay. We can go back short.
Okay. So when you see this kind of hemorrhage in the bladder, the first thing I want you to think of is radiation cystitis. So radiation cystitis will cause all kinds of hemorrhage and fibrin in the lamina propria. Okay, so when you see lots of blood and lots of fibrin, think radiation cystitis. And remember, radiation cystitis will cause crazy cytologic atypia. However, this actually is not radiation cystitis. This is the second entity that I want you to think about when you see this much hemorrhage in the bladder, and your clue is right here. So my question to you now is, what's all the pink stuff?
A lot of
What are these? These structures. What's wrong with the walls?
Yeah, thick wall.
You're right. Why are they pink? Exactly. Amyloid. Okay. So then, when you look around, you have to ask yourself, what is all this cracking pink stuff? So this is a case of amyloidosis of the bladder. And now when you look, you see all that pink stuff? That is all amyloid. Okay? See? See how pink the lamina propria is? This entire bladder is stuffed full of amyloid. And amyloidosis of the bladder will cause rip-roaring hemorrhagic cystitis and also causes this kind of look. But see how pink everything is? You should never have stuff be that pink in your TURBT specimens. And now you can see it really well in the walls of the vessel, right? So once you figure that out, see. Oh, I did not bring the stain. But anyways, that's all. I thought I had brought the Congo red, but I did not. So yeah, so that's amyloidosis of the bladder.
This can be systematic?
No, not always. So some patients have, plasma cell dyscrasias that go along with this, and sometimes it's just isolated.
So if we have this kind of case, would you ask the clinician to do the do the light chain?
I don't ask clinicians to do anything. I just tell them there's amyloid in the patient's bladder and they can do whatever they want. So before I was a pathologist, I did a residency in urology, and then I did path. And while I was doing my path training, I worked as a surgical hospitalist. So I feel like I have treated patients for almost a decade, so I don't need to be doing that anymore. So yeah, you just give the information to the clinician and they're going to do what they need to do. And if there's a question, they're going to call you, right? So I think it's important to know about the entities, and especially, if they said, does this person have a plasma cell dyscrasia, you could say maybe, and they need to be worked up for it. But I wouldn't necessarily tell them how to manage the patient unless they asked. But that's just my philosophy on things. So, All right. I guess you're up. So bladder or testis? Testis. Okay. So this is a softball one. Ha. And pun intended. So this is going to be your 10-second diagnosis, okay? So I'm going to show it to you. You get 10 seconds, right? This is one of those slides that comes up on the boards, and you want to diagnose it and move on. Go. 8, 7, 6. No pressure. 5.
Seems like
4, 3.
the seminoma.
Good job. It's seminoma. Yes. Good job. So 10-second diagnosis. So this is one of those tumors that's like diagnosis from space, right? So you have these fibrous septae. Okay, they're lined with lymphocytes. You go closer. Seminoma loves lymphocytes. Tons of lymphocytes in the septae. And then you have these cells. They have clear cytoplasm. One of the cool things about seminoma that you probably haven't noticed, and you will now notice from here on out, is that a lot of the nuclei are in the shapes of boxes. And I don't know why that is, but they just are. So they're very box-like. Anyways, but yeah, supposedly they have this fried egg look. I don't eat fried eggs. God knows I don't know how to cook a fried egg, but apparently they look like fried eggs. So clear cytoplasm, big nucleolus, fibrous septae, lymphocytes. So this is one of those slides. You see the seminoma. You make sure there is not any other type of germ cell tumor. You can look for GCNIS, right, germ cell neoplasia in situ, and then you move on. All right? Okay. Who's up next? I guess we'll go with you. Bladder or testis?
Surprise me.
I don't know how to surprise people. And typically when I do, it's not surprises they like. So yeah, bladder or testis?
Testis.
Testis, okay. Okay, here we go. Oops, can't go lower than this. Okay, so I'll just show you the low power view. So far you're thinking what?
So far I'm thinking looks pretty dense and filled with cells and,
Yep, so you want to,
and some fibrous looking stroma.
and these are big pools of
Blood.
necrosis.
Necrosis.
Okay.
This is chunks.
And so you're not the person who's on. Okay, continue.
Yeah, I mean, this looks like a bunch of dying cells, polymorphic.
Yep, very pleomorphic.
Yeah.
Would you say that there's nuclear overlap? Are the nuclei falling on top of each other?
Yeah, kind of.
Yeah.
Not really.
Not really?
No, here they are. Yeah.
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 Right. So when you see something like this, right, you have numerous cells that are on top of each other. So, and they're very pleomorphic. You have necrosis. So what are you thinking? Really, really ugly, super ugly tumor.
Some sort of germ cell.
Yeah, okay, what type?
Embryonal.
Right, very good. So this is one of those tumors that you look at, and from space, it's falling apart. It looks like, you know, a big blue mess, essentially. There's areas of necrosis. And then when you look at the cells themselves, they're horribly pleomorphic. There's apoptosis. And, you know, as opposed to like seminoma, where every cell kind of gives, you know, space to every other cell, this is like the subway, you know, where everyone is like piling on top of each other. And so this is embryonal. Embryonal is one of the few ones that has like this crazy pleomorphism plus the nuclear overlap. Okay, so if you are looking at a germ cell tumor of the testis and you're thinking, wow, that is the ugliest tumor I've ever seen, it's probably embryonal. Okay, so that's great. So we have embryonal. So you're going to call this a pure embryonal carcinoma. Is that what you're going to do?
Sure.
Yeah, but no. So here's the other part. So what's going on here?
These cells. This looks like a seminoma.
Right, exactly. It is. So here's your seminoma. So we have a seminoma component here. So again, you know, some fibrous septae, cells with clear cytoplasm, right, kind of box-like nuclei and lymphocytes. So we have seminoma over here. We have embryonal over here. So the way you're going to sign this out is this is going to be a malignant mixed germ cell tumor comprised of embryonal, which is like 90%, and seminoma, which is 10%, right? What else is important in germ cell tumors in terms of reporting? What am I showing you here? Well, okay, so yeah, so GCN, so ITGCN is now GCNIS. Yeah. So, but yeah, so germ cell.
Vascular invasion.
Yes, right. So lymphovascular invasion. So, testis is one of the few organs, it may be the only organ, where lymphovascular invasion causes you to go up in stage, right? To go from a stage 1 to a stage 2. So if you have a non-seminomatous germ cell tumor, okay, stage 1 combined to the testis, what happens to the patient?
So
Yeah, they get their nut taken out. What else?
Chemos.
Do they?
No, surveillance.
Yeah. So the recurrence rate for stage 1 germ cell tumors in general is about 30%, which means 70% of patients, if they have a PT1 N0 tumor, because they'll do a CT scan, then 70% of those patients are cured with orchiectomy alone. You have lymphovascular invasion, that puts them into a higher risk category. If you have high embryonal component, that puts them into a high risk category, then they're going to go and get chemotherapy, right? So it's a big difference between a T1 and a T2 tumor. And lymphovascular invasion is definitely a part of that. And when you call lymphovascular invasion, you really want to see fibrin and tumor cells that are adherent to the wall of the vessel. Because remember, you can have a lot of artifact as you cut through a germ cell tumor, especially seminomas. Cells can go everywhere. So if you just see cells floating in a vessel, no fibrin, no clinging to the wall, no obvious sign that it's that it's really has established a home in there, you're not going to want to call lymphovascular invasion on that and potentially subject a patient to chemotherapy if they don't need it. And then on the exact opposite side of that, if it's there, you have to identify it and you have to call it, because otherwise this patient will recur and they needed chemo, immediately. And if they don't get it, that could be bad for them. So we're going to look for vascular invasion, which we have here, and then there's really not any germ cell neoplasia in situ here. This actually looks okay. All right. Good job. Okay. Who's up next? All right. Testis? Okay. All right. So, thoughts. I'll show you the whole thing. So first we have areas like this. What are you thinking here? Or if you don't know, that's okay.
Yeah, I know. So it's not like hyperchromatic. But
Yeah, I mean, sure. There's this structure here that looks kind of like what?
like a duct.
Kind of looks like a gland, right? And the stroma is kind of like a myxoid stroma, right?
Right.
Right, okay. And we'll move around. More of these gland type structures, okay? All right, and what about here? Kind of trabecular, right? Yeah, kind of trabecular. Okay, so we have these gland-like structures floating in sort of this myxoid matrix. We have some trabecular areas, and let's see if we can find the last area, which is more common. We have stuff like this, where we're starting to get almost like a microglandular kind of appearance, right? Or microcystic appearance. All right, so kind of a microcystic areas, glandular areas, trabecular areas. So give me some thoughts. What do you think?
It's like a sex cord stromal tumor.
So what are our sex cord stromal tumors?
Leydig cell.
What else? So Leydig cell. So does this look like a Leydig cell?
No.
No. So what other sex cord stromal tumors?
Might not be sex.
It's not sex cord stroma. There you go. What's this right here? What's this?
Looks like keratin.
It's keratin. Yeah, sure. It's keratin. Absolutely. Okay, so you immediately know there's at least.
Oh,
This
sorry.
is it. Go back to playing on your phone.
He's still playing and he's still answering.
That's right. Okay, so, right, keratin means, does keratin belong in the testicle? No, not so much. If your testis has keratin, that's a problem. Okay, right? Like, there are certain things your testis should not have, and keratin is one of them. All right. I'm not judging, okay? I'm just saying. Not saying, I'm just saying. Okay, so you immediately know there's a what component?
Like metastatic. No, sorry, but like squamous kind of.
Which equals, in the germ cell tumor world, tumor plus mesenchyma or epithelial structures that don't belong there equal teratoma, right? Right, teratoma. Okay, so if you see cartilage, skin, bone, any sort of things like that, in the testis, especially keratin, right? And you're saying, okay, we know that this is a germ cell tumor, and there's a teratomatous component. But the rest of this is clearly not teratoma, right? Maybe it could be. Maybe you're thinking some of this stuff looks like glands, and maybe some of this is very primitive glands, possibly. But I will tell you that the majority of this is not teratoma, and this is a mixed germ cell tumor. All right. So we just looked at seminoma. Is it seminoma? No. Is it embryonal? Okay. So what else is there? Yeah.
So this one,
Hmm?
this one is polyambroma.
So hold that thought. So this is yolk sac, okay? And all of it is yolk sac, okay? And I will prove it to you very shortly. So the yolk sac has the many looks, okay? Many, many different morphologies of yolk. So everyone thinks about the Schiller-Duval body, which, you love to see. And the Schiller-Duval body is there's a vessel in the center, and then surrounded, it's sort of similar to this, this is not exactly one, but typically you'd have a vessel in the center, you would have then a clearing, you'd have tumor cells, and it's all within a space, okay? Sort of like this, right? But the Schiller-Duval body is actually the least common form that you will see in yolk sac. Most common is actually microcystic. So I will tell you, if you ever see stroma that looks like myxoid stroma, immediately think yolk. Yolk is almost always goes along with myxoid stroma, okay? And especially microcystic formation. So microcyst, myxoid stroma, think yolk. But yolk, as you can see here, it can look glandular, it can look microcystic, it can look trabecular. All of this is still yolk, all right? And now I'll prove it to you. So this is what stain? What stain am I putting up here? What stains yolk?
Yeah.
AFP, right. So this is alpha-fetoprotein, which stains yolk sac, right? And the easy way to remember that is choriocarcinoma, is like a malignant placenta, essentially. Although I hate placentas, I think they're all malignant. They're all out to get you. But so if chorio is like a horrible pregnancy, how do you know you're pregnant? You look for HCG, right? Okay, so that leaves alpha-fetoprotein, because when I first started off, I would always get them confused. So that leaves yolk sac with alpha-fetoprotein, right? Glypican also is a great stain for yolk. And you can see here that our teratomatous area, the keratin, right, is not staining. So we have some nice areas of teratoma, and then the rest of this is yolk. All right, so the many faces of yolk sac. Okay, moving on.
So I'm
Yeah,
sorry, the
go ahead.
question is, it's not polyambroma?
No, so that is an old term, so you would not use that. That is like a term from years ago, so no. So the whole concept of like the polyembryon or whatever it is you think of like teratoma, or not teratoma, actually it was yolk sac plus embryonal, okay? And they would make these kind of like embryoid bodies. And it's just another morphology. But the way we diagnose germ cell tumors now it's either a pure seminoma or it's a malignant mixed germ cell tumor composed of, and you give the percentages of each component. And those are your diagnoses. Okay, so there's no teratocarcinoma either, right? Those are old terms. So, and if you look at the new WHO 2016, it tells you all the different things that you need to put in there. But you need to mention whether there's germ cell neoplasia in situ. You need to mention, obviously, whether there's lymphovascular invasion, if there's invasion of the tunica albuginea, if it's penetrated all the way through that, if there's invasion of the reedy testis, if there's invasion of the epididymis, if there's invasion of the hilum, right? Spermatic cord. And so when you get a germ cell tumor, it's really important to section it thoroughly. Because, for example, if you have taken all of your tumor sections and you don't have hilum, where you should see some fatty tissue and reedy. So if you don't have those sections, you need to go back. Same thing, you can't just lop off the end of the cord and as because your spermatic cord margin, and then just say that's my representative section of cord. Because where is the tumor going to invade cord first? It's at the base, right? It's not like going to jump all the way to the margin. But I've seen many testis cases come in as consults where they've just basically lopped off the spermatic cord margin and there was no other section of cord. So that's not great, right? So these are all things to think about. Okay. Oops. All right, moving on. I think you're up, sir. Bladder. Good choice. What do we have for you today? All right. Okay, so from low power, any thoughts?
Just bladder.
It's bladder. So what's the first thing? Why did you ask that?
I mean, the squamous and the keratin shouldn't really be there.
Well played, sir. Well played. Yes, that's correct. The keratin should not be there. If you see, so this, if you just had this, what would your diagnosis be?
Edematous adnexal skin.
No. Try again. Starts with an M, ends with an etaplasia.
Yeah.
There you go. So this is keratinizing squamous metaplasia. Is that the same thing as non-keratinizing squamous metaplasia?
No.
No. What's the difference?
Keratinizing is keratin.
Indeed.
No, keratinizing is more final, it's more end stage, it's not as aggressive as non-keratinizing.
Okay, so you're close. So non-keratinizing squamous metaplasia, if you're a female and you're sitting in this room, or virtual females not in this room, I don't know I assume they're out there. It's creepy, actually, thinking about it. But if you're a female and you have a trigone, you probably have some non-keratinizing squamous metaplasia, right? Why? I don't know, man. It looks like little white bumps, okay? And we have it. So congratulations. Yeah, that'll keep you up at night. Okay. And that's okay. Like, squamous metaplasia in the bladder, it's fine. They used to be called transitional cells, right? Because they're changing into something, and the squames happen to be there. So fine. Keratinizing squamous metaplasia is very, very bad. First of all, they think it's a precursor lesion to squamous cell carcinoma. It's also associated with squamous cell carcinoma, which means in many patients where you see keratinizing squamous metaplasia, if they dig underneath the surface, somewhere in that bladder, there's a squamous cell carcinoma. Okay, so never, ever, ever blow off keratinizing squamous metaplasia. And you talk about making comments in path reports. Normally, I am a minimalist, okay? I tell clinicians what they need to know because as a former clinician, I gotta tell you, we don't read reports. Like, I hardly read my own reports even still. So, you gotta keep it brief. And that's ironic coming from me who speaks a lot. So the point is, in this, I make a comment. Because if you just say keratinizing squamous metaplasia, your urologist won't know what the hell you're talking about. Okay? So in this case, I will say, and by the way, they might have a squamous cell carcinoma located somewhere else in their bladder, and you might want to do another TUR. Okay? Or at least say keratinizing squamous metaplasia is associated with squamous cell carcinoma of the bladder. Close clinical follow-up is recommended. Because otherwise, they may not know. And it's important. So there's keratinizing squamous metaplasia of the bladder. But there's also other stuff too, right?
So split a hydrocellular area with multiple, not so pleomorphic cells.
Yeah. But not normal, is it?
No, not normal.
So, okay, what does anything stand out about these cells?
Yeah, the cells, especially in the bottom, they have whatever the screen, they actually have a nuclei and kind of eosinophilic inclusion with them.
That's right. Yeah, they almost have like these little pink blobs that are pushing the nucleus off to the side. So now what are you thinking?
Yeah, there was something about that. Yeah.
Yeah, you see all the pink blobs, and once you see one, like you see them all, right? They're everywhere.
Yeah, there was something about that.
Yeah?
I can't remember the name.
Right, exactly. Okay, you're good. You have kind friends. Your colleagues are there for you. Right. So this is rhabdomyosarcoma. That's great. Good job. So not only we have keratinizing squamous metaplasia, and then you see all these other cells here. And what was interesting about this case is this case came with a history of the patient was originally seen at an outside hospital, and they said the person had adenosarcoma of the bladder, and I said, you mean like an adenosarcoma of the uterus? And they're like, no, it was diagnosed as adenosarcoma of the bladder. Yeah, no, so that's not what this is. So this is a rhabdomyosarcoma of the bladder, which you can see in children, but you can also see it in adults. It's not uncommon. You can see it as a part of, like you can have carcinosarcomas or, urothelial carcinomas with sarcomatoid differentiation, where the sarcomatous component is rhabdo, or you can have cases like this where it's just a pure rhabdomyosarcoma. All right, so it's something to be thinking about. Anyways, and when people think about rhabdomyosarcoma, I think you think about like seeing Z-bands and whatnot. When I was a resident and studying for the boards, I always pictured rhabdomyosarcoma as having these beautiful long pink tails, and you'd be able to see Z-bands. And that's not real life. So real life, rhabdomyosarcoma is a small blue cell tumor. Okay, so just from here on out, when you see a small blue cell tumor, think rhabdo, think desmoplastic small round cell. Think lymphoma, think Ewing's, which is / peanut, right? But always think about rhabdo, and especially in the bladder, blue cell tumor, think rhabdo. So especially when you have these little pink blobs, because most of the time that's all you get. You get blue cells with pink blobs off to the side. All right. Okay. Very good. Next victim. Bladder or testis?
Bladder.
Wait a second, we didn't finish the table.
Testis.
Testis. Good man. It's a good choice. You're on the ball. All right. I appreciate that laughter. Thank you. It's a tough crowd. Okay. So, this is like first thought. So, my friend, Dr. Yard used to say she would look at something and ask herself, would I accept this tissue into my own body? And if the answer is no, it's probably not normal. So would you accept this tissue into your own body? And the women are saying no, and they don't even have testicles. So I hope to God that the guys say no. Would you like your testes to look like this? No. You want to have children someday. Well, maybe you don't. I have 3, so maybe, trust me, you may not want to. It's a horrible thing to say, but they can't hear me. They're 6', 4, and 15 months. So, and my incredibly understanding husband is home watching all 3 of them. So, I can't wait to go home and see the house after this little trip. Anyways, but it's okay. My criteria is like, just keep them alive for 48 hours. Whatever happens to the house is fine. He's like, yeah, I can do that. Okay, so this is a problem, right? Even an old dude should have every single seminiferous tubule making sperm, right? You shouldn't have like lazy seminiferous tubules. Your seminiferous tubules should be making sperm. That's the only thing they have to do, and they should do it. Okay, they can't be lazy. I mean, otherwise, just what's the point? Okay, so when we look at seminiferous tubules, you want to see nice germ cells down here, and as they progress to the center, they get smaller until the center you have like little spermies that are going to swim off, right? And then you want to be able to recognize Sertoli cells, and that's really simple because the Sertoli cells have this really nice prominent nucleolus, right? And you can tell the difference between them and the germ cells, which tend to have more like speckled chromatin, okay? So as long as you can tell that, because inevitably someone's going to do a test question where they're like, what's this cell? And you're like, I don't care. And then you're like, oh crap, I need to get board certified. I do care. And then it's too late. And, you fail. Okay. I'm also a motivational speaker. So I'm like, look, you're going to fail. Just don't try. Then you can't, then it just won't matter. Just don't try. It also works with children. So, so if you're inside the seminiferous tubule, you got your Sertoli cells, you got your germ cells, and then honestly, if you're not in the seminiferous tubule and there's an arrow pointing to anything, even if you have no idea what it is, just say it's a Leydig cell because you're probably going to be right, because what else is out there other than vessels? Leydig cells, right? Okay. But that's what they should be doing. So when you have this, where you have all these sclerotic seminiferous tubules, that's not normal, okay? And when you see something like this, and you see coarse calcifications, fibrosis, typically there's a germ cell tumor lurking nearby. So if you ever get a biopsy for infertility, right, where they're trying to, get the guy's trying to get the wife pregnant, and maybe he's shooting blanks, and so they're going to do a little biopsy, see what's going on. Remember that the infertility population is always at high risk for testis tumors, okay? So if you see a lot of fibrosis, sclerotic seminiferous tubules, coarse calcifications, really keep your eye out for germ cell neoplasia in situ, and you always think that there could have been a regressed germ cell tumor. Sometimes you will also see patients present with metastatic disease, and all they have in the testis is a scar. So actually in the reporting system, when you have say you see a pure seminoma, if you have pure seminoma plus scar, that means there's a regressed component, right? And you need to report that because it's not necessarily seminoma that has regressed. It could be anything, right? Okay, so food for thought. Anyways, this is not a germ cell tumor. This is something else. So we have some normal seminiferous tubules, some sclerotic seminiferous tubules, and then this. So first of all, how would you describe it from low power? Is it infiltrative? Yeah, it's well circumscribed, non-infiltrative, and you need to just go back to your phone and stop answering for other people. All right, just get out. All right, yes, so well circumscribed, not infiltrative. What do you think of the cells? It shows better on the screen like that.
Cells are hyperchromatic and pleomorphic.
Okay, so cellular I'll give you, hyperchromatic I'll give you. What's going on with the stroma?
And the stroma is dense with hemorrhage.
Well, it's not really hemorrhagic so much as it's hyalinized.
Yeah, hyalinized.
Exactly, so it's really pink stroma. Now let's look at the cells. So when I think about the word pleomorphic, I think about embryonal carcinoma, right? Nothing is more pleomorphic than our friend embryonal. Does this look like embryonal to you? No, cells, the nuclei are small, right? They're small little blue cells, right? And you see any mitoses in there?
Yes.
Nah, there's none. It's that's a lymphocyte. So, and there's some neutrophils. You can see it better under the microscope. But these cells are actually not that pleomorphic. They all pretty much look like each other. Now, they don't have a lot of cytoplasm, and they're very, very blue. So can you think of any germ cell tumor that looks like this? No, right? So it's not a germ cell tumor. Okay, so now what's your next guess? So once you're like, okay, let's list off the germ cell tumors. All right, we got chorea, we got embryonal, we got seminoma, we got yolk sac, we got teratoma, and this doesn't look like any of them. So then your next category is...
Sertoli?
Well, if you're in an ovary. But yeah, sex cord stromal tumors, okay, which you can have Sertoli cell tumors and Leydig cell tumors. And if you're in an ovary, then you can have Sertoli Leydig cell tumors, right? Which is kind of, anyways, I'll tell you that other story. Which I once had a frozen on an ovary, and I said it's a Sertoli Leydig cell tumor, and they said, Sertoli and Leydig cells? They're like, isn't that only in men? It was like this awkward silence, and I was like, no.
Why are you putting it to people?
Right. I was like, it's just, I'm like, this is just awkward, and I'm hanging up on you. Anyways, yeah. And the sad thing, I don't even think the OBGYN had enough knowledge to even be embarrassed, but we felt embarrassed for her. I'm like, when your pathologist is laughing at you behind your back, that's not good. Okay, so this is a sex cord stromal tumor. So you have your Sertoli cell tumors and you have your Leydig cell tumors, and the Sertoli cell tumors are blue and the Leydig cell tumors are pink. And this one is blue. So it's a Sertoli cell tumor. Is it malignant? If you had a guess, are you a betting man? You're not a betting man, or you just?
No, it's well confined, so I don't think it's invasive or malignant.
Right, exactly. Yeah, it's first of all, it's small, right? This whole thing was like, a centimeter or 2 centimeters. And it's well circumscribed. And when you look around, you don't see any necrosis, you don't see any mitoses. So this is pretty much benign. You know it's going to be benign. Are you going to call it a benign Sertoli cell tumor?
Yes.
No, you're not. Why? Because 10% of them are going to be malignant, and you just don't put your neck out. I tell my residents, don't be a giraffe, and they're like, what the hell are you talking about? I'm like, giraffes, they have really long necks. They're always sticking their necks out. They can't help it. They have long necks. Why does no one understand that? Anyways, don't be a giraffe. Don't stick your neck out and get it cut off, right? Although I don't know how you'd cut off the neck of a giraffe. It would probably be very difficult. But anyways, how would you reach it, first of all? But the point is, yes, 10% of sex cord stromal tumor of the testis are malignant. Now we can say, first of all, if it's infiltrative, if it's mitosing, or I like to say mitoting, if it's mitotically active, if it's infiltrative, if there's necrosis, we can say this could have malignant potential, right? Or we can say there are none of these features, and this is likely to have a benign clinical course. But it would be a comment. Your bottom line is going to be Sertoli cell tumor, period. You're not going to say whether it's benign or malignant because 10% are malignant, all right? 10% of Leydig cell tumors are malignant. Same criteria. You're going to look for infiltrative pattern, mitoses, necrosis, right? Okay. Strong work. Moving to the back row. Bladder. Okay, so let's see where we're on bladder. Oh, this is a good one. Okay, so this is a TUR specimen, TUR BT, transurethral resection of bladder tumor, or as I like to call them, turbits. And, all right. And this is it. This is all you get. And go. So this was almost, I will tell you that this was brought to our consensus conference one day, and they put down the slide and said, yeah, there are these things here. I don't know what they are. I think I'm just going to blow it off. At which point I stroked. So what do you think? I got better. Anyways, go ahead. Thoughts? Do you need to phone a friend?
Do you have emails for this?
Nope. What do you mean? Know what you order?
I mean, can they like WT1 or something?
No, that wouldn't help you. It'd be negative. Then where are you at? What about our victim? We haven't called on our victim today.
Yeah, I will pass this one.
You're like, I don't know what it is, but it's not malignant, so it must be okay, right? So no. Okay, so let me take you around and see if I can help you out. Okay, now what is it? The bladder. Hey, you're still up. You got a picture. Oh no, you've got to go. Okay.
You saved me.
That's right. So since I picked on you, let me at least go through it. So here we have this papillary structure, right? And we have these atypical cells. And so this is obviously a papillary urothelial carcinoma, right? So then that brings up the question is, what are all these things? So in that context, what are these structures? They're fibrovascular cores. They're completely denuded fibrovascular cores. So at Hopkins, we would call this, I'm not kidding, pap nude. Okay, that was our slang, our macro for this feature. So what can happen is you can have high-grade papillary urothelial carcinoma. The cells are very discohesive and they shed. And this is why urine cytology works, right? Is because the cells will shed into the urine, then you pee them out, and our cytopathologists who I think practice voodoo can actually see them, right? So these structures are like essentially ghosts of tumor past. These are the denuded fibrovascular cores. So if you see this, if this is all you have on your biopsy, and that can happen, you have to say, this is a papillary urothelial neoplasm. Now, you can't grade it, and you can't even tell them if it's like papilloma or cancer, but you can say that this feature is associated with high-grade tumor, okay? And they need to know that. But you can't blow it off because this is actually a papillary tumor of the bladder. All that you have left is the fibrovascular cores, but that is absolutely a tumor.
Do you recommend to do another biopsy?
Oh yeah, absolutely. Absolutely. Or tell them to get urine cytology, because the cells are probably in the bladder somewhere, and they might be able to see them on cyto.
So for this one, initially I thought is, can you, consider adenomatoid tumor?
Not in the bladder. If you were in the paratesticular area, sure, you could have a mesothelial tumor. Not in the bladder.
But the tumors that have this feature have a worse outcome?
No, they just tend, well, if they're high grade, yes, but denudation in of itself is not necessarily a poor prognostic indicator. What it tells you is that they have a tumor, and denudation tends to go along with high-grade tumors. But it's not always. But you just need to, because they need to, and urine cytology would be very helpful, because here you tell them, look, there is a papillary urothelial neoplasm in this bladder. If they get cyto and it's high-grade, then they know how to proceed, right? That's BCG. A low-grade papillary non-invasive tumor, you would not treat with BCG, you would just recysto in 3 months, right? So it's very different. So, and actually that's an important point, is that when you're distinguishing between a low-grade tumor and a high-grade tumor, especially if it's non-invasive, that makes a big, big difference in management of that patient. So you have to be very careful. So when we're looking at high-grade features, we're looking for pleomorphism and polarity, right? Mitoses kind of come in secondarily if they're getting off the base. So you can see in this one papillae we have here, you've really lost your pleomorphism, or sorry, you've lost your polarity. You like to see urothelium lining up like a picket fence, right? Although I haven't really seen many picket fences in my time here in New York, but I assume you guys know what they are. So if they're not lining up like that, and then you see gigantic dark nuclei, that's a good enough for high grade, okay? But you don't want to overcall high grade, and you don't want to undercall high grade, right? So anyways, but so it's all about pleomorphism and polarity, okay? All right, pap nude. Okay, who's next? All right.
I'll do bladder.
Bladder. All right, here we go. It's one of my favorite tumors. Okay, from space. Thoughts?
This is,
Read the space.
Oh my gosh. Who is this guy?
He's our lawyer.
He's well, I guess it's like a necessary evil, I guess. Okay, thoughts from space.
So you have very dense cellular areas.
Okay.
With intervening fibrostroma, it looks like papillary.
Interesting, interesting. So it's interesting that you say it looks papillary. So I will challenge you on that and say, if it looks papillary, where are your fibrovascular cores? That's true, right? So I would say that these are anastomosing trabeculae and small nests of cells. I would say there's some peripheral palisading here. The cells are spindled and kind of streaming in the middle. And they're all very similar, right? They all look pretty much the same. Okay. And when you look around, there's this a lot of cautery artifact, but you don't really see any fibrovascular cores. So you don't see, the question is, if this is a papillary tumor, where's the exophytic component? And I'll tell you, you don't see an exophytic component because it doesn't have an exophytic component. And here, this is a good example of what's going on. So here's your surface right here. There's your surface urothelium. And everything else is underneath. Now, in the true sense of the word invasion, does this look invasive? Meaning, do you see any sort of desmoplastic reaction, or it's just sort of sitting there, right? Right. So what is that called? What kind of growth is that?
Inverted.
It's inverted growth. So this is a...
Inverted papilloma.
That's right. It's an inverted papilloma. Right. So this is a benign inverted inverted urothelial papilloma. Now, you have to be very careful with this diagnosis. So I will tell you that this truly is an inverted urothelial papilloma. Now, the literature, and let me just, so inverted urothelial papillomas. Okay. So thin trabeculae, right? Not thick trabeculae. So now remember, in about 25% of urothelial carcinomas, you can find areas that look like this, right? So how do you know it's a true inverted urothelial papilloma, which should be benign? Number one, thin trabeculae. Number two, peripheral palisading, spindled nuclei on the inside. No cytologic atypia, none, zero. No mitoses, okay? No exophytic component. If there's an exophytic component, it's not an inverted urothelial papilloma. It's a carcinoma that has inverted growth, right? Huge difference. You should not see necrosis in these things. You can see sometimes some squamous morules, and that's okay. But notice, it's just sort of sitting there. So as long as you stick to the strict criteria for this, then you'll get it right. So this is an inverted urothelial papilloma. So a lot of the literature is very, there's a lot of debate, do these things have malignant potential? Can they recur? So yes, they can recur if you don't get them all out, absolutely. It is thought that the true inverted urothelial papillomas are benign, okay? They will not have malignant progression. And the reason that there's debate about this in the literature is that there are some series that have said a small portion of them become malignant. But we think now is they were misdiagnosed. All right, they were truly urothelial carcinomas with inverted growth that were mistakenly called inverted urothelial papilloma. So if you apply the strict criteria, right, where there's no cytologic atypia, there's no mitoses, and there's no exophytic component, then that should be benign. So there you go.
I have a question.
Yes.
About the overlying epithelium, that
Yes.
would be like, and if it is like a carcinoma, so will there be any changes, like the high grade or?
Yeah, absolutely,
Okay.
absolutely. So if you have, so actually, if you notice here that the tumor has kind of colonized the surface almost, and you notice that the surface looks actually very similar to the lesion, right? That's pretty classic. I mean, you can see that with a lot of things, but you would expect, and notice though, the histology is identical. Right, and that's okay. But yeah, if you are starting to see any sort of atypia, if you see carcinoma in situ on the surface, then that's a problem, right? Yeah, absolutely. Yeah, the surface should look like the tumor cells, or it should look normal. And these things can get really big. So I mean, 5 centimeters even. So that doesn't necessarily mean it's a carcinoma. Okay. Testis, bladder? Testis. Okay, where were we at? Let's see. Did that one. This is so I will tell you right now, if you get this, I will be incredibly impressed, because I got this during my fellowship and I said, what the heck? So straight from Hopkins, here it is. So this is a hydrocele sac. Okay, so it's just a lot of fibroadipose tissue, some fibromuscular tissue, and these guys. So the question is, what are the blue balls? Any guesses? I will open this to the room. Yeah. This. Here, I can show you more. There it is. They're everywhere. The more you look, the more you find them.
Is it malignant or infectious?
Yeah, it's gonna go infectious.
Okay, so if it's infectious, what do you think? Okay, it's a thought. Oh, look at this guy. Okay, so the suspense is killing me. So yeah, this is a totally benign phenomenon. So what this is what if I put this inside the testis, what might you think about? If I put it in the epididymis, what would you think about? Yeah, you might think about sperm, right? Yeah, like a spermatic, like a granuloma. Exactly. That's exactly what's going on. So what is so this is patients who have hydrocele sacs can have spermatoceles, and this is basically sloughed sperm and epithelium, and it goes into the hydrocele or spermatocele, and it coalesces, and it's totally benign. This is just normal structure, and there has actually been an article written about this, and the title was "Blue Balls in a Hydrocele Sac." Okay, so that actually is the diagnosis. So you could say there are blue balls, if you get this as a consult, blue balls in a hydrocele sac, and reference. That is what it is. You just say it's benign. It's sloughed tissue, and it's totally fine. In case you ever see that in your hydrocele sac, it's okay. Okay. Last but not least. Bladder. Oh, all right. Let's see here. What we got? So this one. Let's see. Oh yeah, it's a classic. Okay. So first thought. What is wrong with this? First of all, I'm telling you this is bladder, but what's wrong with it? It's too pink, right? I mean, it's like, you're like, I mean, I know there's lamina propria, but this is like, what is wrong with this lamina propria? Okay. So, what are you seeing here? Yeah.
Chronic inflammation.
Chronic inflammation, absolutely. And then you see all this pink stuff, right?
Yes. So these vessels.
So what are the pink cells? That's your first question. What are the pink cells? Lots of chronic inflammation. So I will tell you the pink cells are histiocytes, okay? And that means there's an absolute ton of them, right? So what entities in the bladder are you going to think about when you see this much? And I would say you see this much chronic inflammation, and especially this many, macrophages / histiocytes. I want you to think of a couple of things. So what is one of them? Yes. You guys. Yes. Okay. In case you wanted to have a guess. Okay, so inflammatory conditions of the bladder. Name one. Oh no! It's just, sure, okay. Okay, so yes, I heard malakoplakia, okay. What other things? This histiocytes, bladder. Yes, your first thought is malakoplakia. What else can you think about? Rosai-Dorfman, excellent. Okay. So now, and then I would say one other entity you should think about when you see tons and tons of inflammation in the bladder, although it's typically not a stromal thing, but you should think about nephrogenic adenomas. Oh, I can't go to EM power. Okay, so what is the diagnosis? Sorry, I can't focus it any better. But yeah, this is malakoplakia, right? So Michaelis Gutman bodies. I don't know if you guys can see right there. Yeah, little targeted lesions. And, once you see one, you can start seeing, that there are more all over the place, right? See that? And up there. Sorry, I can't make it any more clear on the screen. But once you see one, you'll start seeing tons of them. So this is malakoplakia. So when you see, and then the other thing, since we're running out of time, you said was Rosai-Dorfman, right? So and I actually did bring a case of Rosai-Dorfman. Let's see, but I think. Let me see if I have it.
What is the third one you're talking about?
Oh, so nephrogenic adenomas. When you see lots of inflammation, think about nephrogenic adenoma. Always, 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 because they can look very, very much like cancer, right? So first, let me just show you a quick Rosai-Dorfman. Just calcifying. Let's find another couple real quick. Okay, so this is back to testis. But so this is a nice cellular infiltrate. Notice it's going in and around the seminiferous tubules, but the seminiferous tubules themselves are intact. Okay, that should always make you think of some sort of like hematopoietic process, right? Most commonly, you see something like this, and you're going to think lymphoma of the testis. But remember that Rosai-Dorfman can involve the bladder, it can involve the testis, it can involve anything, right? And that's when you go down and you try to find the emperipoiesis, right? And once you find one, you can find lots of them. So when you find macrophages that are eating other cells, right? So when one cell eats another cell, that's not good. Shame on that cell. So Rosai-Dorfman, you can absolutely have it in the bladder. So when you see a lot of pink stuff in the bladder, think about Rosai-Dorfman. First of all, think about malakoplakia, especially for the boards and the Michaelis Gutman bodies. When you see a lot of inflammation, always, always, always think about nephrogenic adenoma. So here we have what looks like a papillary tumor, right? Again, I would say look at the lamina propria. It is packed full of inflammation, and that's when you realize that the surface has only one layer thick, right? Urothelium is multiple layers. So anytime you see this much inflammation and a papillary lesion and it's only one layer thick, you have to think about nephrogenic adenoma. And then when you look here, you see that there's a tubular component, right? It looks like vessels, except you're not going to see red blood cells in there. There's more of it. You know, don't be fooled. You can think, oh my gosh, those are signet cells, but notice how they're very hyalinized. See these beautiful hyalinized rings around each little tubule? That's classic for nephrogenic adenoma. You should not see any mitoses in nephrogenic adenoma. If you think you have a nephrogenic adenoma and there's horrible pleomorphism and it's mitotically active, it's probably a clear cell carcinoma of the bladder. Thought. So yeah, when you see inflammation, malakoplakia, number one, think about Rosai-Dorfman, and absolutely think about a nephrogenic adenoma. And they can occur anywhere, including the ureter. Huge difference in diagnosis, right, between that and something that's malignant. All right. And then let me just show you guys one last thing before I let you go. And that is this, because I think it's diagnostically a pitfall that you never want to make. So we have some urothelium here. It's nicely polarized, no pleomorphism. You say, okay, great, the urothelium is normal. You have some muscularis propria, big thick muscle bundles. And then you have this, which is this pink spindled tumor, right? So spindle cell tumors of the bladder. Anyone, go. Sure, you actually can have leiomyomas of the bladder. Do they turn into leiomyosarcomas? Yeah. No, they don't. So yeah, leiomyomas of the bladder are totally benign. You can also have leiomyosarcoma of the bladder, but leiomyomas don't turn into leiomyosarcomas. They don't do it in the GYN tract, and they don't do it here. Okay. What else? What else can you have? Spindle cell tumor of bladder. Nerve cell. I'm not sure. Like, I'm not sure I've ever seen a schwannoma of the bladder. I assume it's possible. Yeah. Okay, but sure. What other spindle cell tumor?
It can be a sarcomotoid carcinoma.
Absolutely, and I think that's one of the first things you think about, right? If you see a spindle cell malignant tumor in the bladder, the first thing you're going to think about is like, all right, it's just a urothelial carcinoma that has sarcomatoid differentiation. You're like, it's probably boring. You know, those are boring. I mean, not for the patient there, because they're gonna, die. But anyways, but this is neither of those things, right? You can also think about rhabdomyosarcoma, right? Yeah, it could be spindled. Normally, it's a small blue cell tumor, but it could be totally spindled, right? So leiomyoma, leiomyosarc, rhabdomyosarc, sarcomatoid carcinoma. There you go. And IMT. So of all those tumors, and you're a patient, if you had to choose, I play this game with myself all the time, like if I have to choose a cancer, which one do I want? Which one would you like?
Leiomyoma.
Well, yeah. And if you couldn't choose leiomyoma, you probably would want the IMT, right?
Yes.
Because it's benign.
Yeah.
Okay, so the question is, which one is this? Is this a rhabdomyosarcoma, or a leiomyosarcoma, or an IMT? Okay, so I hear IMT over here, and I hear it's too pleomorphic for IMT over here. What about our victim? What does the victim think? Victim?
Yeah, I was saying that
Is it too pleomorphic for IMT, or is it IMT?
there's some abnormal, some polymorphism, not too much.
Commit, man, commit.
No, this is you.
Okay, so first of all, what do you see scattered in the background?
Yes.
Right. So first of all, there's a lot of inflammatory cells in the background, which should be your first tip off that, wait a minute, maybe there's the word inflammatory in this condition, okay? But still, you're seeing a lot of pleomorphism, right? And that maybe scares you a little bit. But I would argue that the pleomorphism is actually typical for this type of lesion because it almost looks like ganglia, right? They have these like perfectly, rounded nucleoli, almost like stellate-shaped nuclei. And then look at the tails. So this is an IMT. It's an inflammatory myofibroblastic tumor. And typically, it's the only tumor of the bladder where you will see this kind of length in the cytoplasmic processes. Rhabdomyosarcoma typically doesn't have tails that are that long. These are, look at them. They're super, super long. And then you have this cytologic atypia, but when you think about it, it really almost looks like the same kind of atypia you would see in a ganglion, right? With those beautiful round nucleolus and then lots of this kind of amphiphilic cytoplasm. So this is all IMT. And then you see a sprinkling of inflammatory cells in the background. And I have to tell you, this came as a consult for me in Birmingham. And when I first saw it, I thought, oh my gosh, this is the nastiest sarcoma I've ever seen. And then about 10 seconds later, I said, oh wait, it's an IMT. And that's the features that are going to help you. The inflammatory cells in the background and these kind of things that look like ganglion, right? Okay, so what stain are you going to do for it? ALK. So here is our ALK1. And you can see it's perfectly positive.
So it can be negative too, right? But if it's negative,
So,
would you still...
so if it was negative, I'd be very scared. So I would do a myogenin and a myod1, right, which should not be positive in IMT. So in other areas, so if you look at all IMTs in the body, ALK1 is positive in about 50% of cases. I have yet to come across an IMT of the bladder that is not ALK1 positive. All right, in the bladder, they're almost always positive. And I would give pause if it was negative in the bladder. Can there be negative IMTs of the bladder? Yes, but be very careful that you rule out other things. So you're looking at the urothelium, make sure you don't see anything that looks bad with that, make sure there's nothing that would make a sarcomatoid carcinoma. But most of them have beautiful ALK1 positivity. All right. We are over time, so thank you for being patient.
Yeah, thank you. Nice cases.
Wonderful. Thanks for having me. Let's do this again sometime. Bye, virtual people, if you're still there.